So as Joe said, that our role is to protect, promote and support breastfeeding, and we're really happy to be here with you today. At the end of the presentation, we've got ways to contact us for each of the areas, so you'll be able to access us quite easily. So we're going on to the first slide, looking at the values of breastfeeding for mum and baby. So it's all about early life nutrition for lifelong health. So benefits of breastfeeding are really quite clear. It is a huge public health issue. We know that increased breastfeeding rates contribute to reduced health inequalities through improved outcomes. So some of the benefits we've listed, but obviously there's many more. But breastfeeding enhances the loving relationship between mum and baby, and this leads to improved health, mental health and well-being for both mum and baby, and it affects the baby brain development. Increased breastfeeding rates, it reduces the risk of gastroenteritis, ear, chest and urine infections. It's also been shown to reduce the risk of obesity in both mums and babies. So it affects the breast milk itself, affects the baby, the baby's gut, the microbiome. So breast milk helps to develop the immature immune system, and it creates a hostile environment for pathogenic bacteria, thereby protecting the baby against infections and diseases. Interestingly, with regard to obesity, women's mean BMI was found to be 1% lower with every 6 months that they breastfed. Interesting things with regard to the milk itself. Breast milk contains leptin, which is sort of regulates baby's appetite and reduces the obesity risk. And you know, baby who breastfeeds, because it regulates, then it shows that it really reduces lifelong risks to obesity as well. Breastfeeding reduces the risk of childhood cancers and reduces risk of atopic allergy. A baby that breastfeeds is 50% protected against the risk of sudden infant death syndrome. It also reduces the risk of breast and ovarian cancer for mums and osteoporosis. So these, you know, extensive benefits, they're sort of well known, and each year we learn more and more about the benefits of breastfeeding. So on to the next slide, we have a quiz for you. So let me just bring up this quiz. Right, does that come up, Alison?
Come in. Yeah.
Yes, I can see the quiz. Yes.
Yeah.
Thank you.
And it looks like I can interact with it as well, so it looks like it's working.
Good. So if you'd like to interact and tell us what you think.
Oh, interesting. Joe?
So so at the moment we've got so the question was when do women most commonly quit breastfeeding, and we've got 66% of you thought 2 to 3 days post delivery, and 33% put 10 to 15 days. And it's actually quite interesting, your responses, because the data that we have from quite a few years ago suggests that the biggest drop off in breastfeeding rates is 2 to 3 days, which is because, and actually now we're 50-50 actually on what
People changing their mind.
So that certainly was the case. Well, I looked at the NATH data, so the Nottinghamshire county data, the most recent data we have, which is quarter 4, so the up to April this year, and our biggest drop off was between 10 days and 6 weeks, actually. So we lost 9% between first day and day 10, and then we lost 20% from day 10 to 6 weeks. So I think you know, either of you, if you put 2 to 3 days or 10 to 14 days, I think you could both be correct, actually, because for NOTS it was 10 to 14 days, but actually there's some evidence that that the biggest drop is 2 to 3 days. So I think whichever one you put, you're a winner on that one, I think.
Lovely. And then we have a second question that should just be coming up now. Has that come up, Alison, the second question?
Not for me, no, I can't see it.
Yeah.
Oh, yes, we're looking good now. Yes.
Thank you.
It looks like people are voting, which is great. So it looks maybe like, yeah, so we've got 57% on 6 months, and it's gone to 50-50 now, and 50% 2 years and beyond. So it's quite an interesting question, isn't it? Because the recommendations are to exclusively breastfeed for the first 6 months, and then continue breastfeeding alongside the introduction of complementary foods, up to 2 years and beyond. So it's kind of a slightly trick question. So exclusive for 6 months and up to 2 years, and as long as mum and baby want, alongside the introduction of foods. Thank you.
So it's gone back to the PowerPoint, Alison.
Yes.
Lovely. So the next slide, Jo, please.
Yes, it should have moved on. Has it moved on, the slide?
It's gone on to okay.
Yeah,
so
it is now,
yeah, thank you. So with moderate increases in the rates of breastfeeding, so if what we found, there was an economic report launched, and if 45% of babies exclusively breastfed for 4 months, the savings from certain diseases, from gastroenteritis, respiratory disease, otitis media, necrotizing colitis, and maternal breast cancer, this would equate to a saving of £40 million per year for the NHS, and you can see it broken down. And obviously reduction in infections means less visits to the GPs. So these significant costs to the NHS, and obviously trauma for families as well. Next slide. So what we know makes a difference. So this was developed by Public Health England and Baby Friendly, and it's used as a toolkit for local authorities and healthcare settings to highlight the importance of consistent face-to-face infant feeding support from pregnancy through to early weeks and months. And it really shows that breastfeeding helps give babies the best possible start in life. So the first one, raising awareness that breastfeeding matters. It really does matter. Initiation across Nottinghamshire varies between 59% in some areas and 80% in other areas. Indicating that most mums want to breastfeed. So we really want to support families to reach their goals and to provide information antenatally to really empower women so they know how to get breastfeeding off to a positive start. We also want to ensure that women who are ambivalent have the opportunity to give breastfeeding a go if they would like to, just to make sure that just not knowing anything about breastfeeding isn't a reason not to breastfeed. And then we're keen to offer support early on in the early days to ensure that problems don't arise. we will share with you later on the support in the community, but it's all about providing effective support to mums and their families at a time when they need it. And then the final one, restricting the promotion of formula milks and baby foods. Again, we've got a little bit more later on in the presentation, but it's looking at the problems with the advertising of formula milk and how that affects families. So the next slide. So as GPs, for us, it's important to work in partnership and support each other. But this is the words of one mum. My health visitor asked me to see my GP and she suspected my baby had oral thrush. The GP took the time to ask how breastfeeding was going, and he congratulated me on breastfeeding. He could have given me a prescription and said no more, but those few minutes gave the mum a real boost. And mums, you know, to feel their confidence, the fact that they're doing well is really important. And that's been taken from the GP Infant Feeding Network. Again, we'll provide you the link to that. It's a really good resource. It's run by GPs. I think you might find it helpful. Moving on, so the role of the GP, and this is taken from the GP Infant Feeding Network. There's several things, you know, support that you can give to initiate and continue breastfeeding, and it's having that confidence to manage common breastfeeding issues, and the appreciation that clinical issues relating to infant formula, the fact that if a mum's breastfeeding, giving supplements can affect her breastfeeding adversely unless it's medically implemented. But really importantly, it's about directing them to practical support with position and attachment where necessary, because it really is crucial for mums to get the support early on in the early days, and to provide evidence-based advice and personalised support to help them feed successfully and pain-free. It talks about an understanding of the International Code of Marketing of breastfeeding substitutes, and the responsibilities that we have so that we can ensure that families who choose to bottle feed do so safely, and families who want to succeed in breastfeeding aren't pressurised to offer bottles, and also to believe that they can make as much milk as that baby needs. Next slide, please. Right, so we're going on to another quiz, and this time it's about data. It's coming up.
I can't see it just yet. Oh yes, there it is.
So which area in Nottinghamshire has the lowest breastfeeding prevalence rates? Interesting. Mansfield and Ashfield, in fact, Mansfield did have the lowest rates for a while, but Bassetlaw has actually taken over, and Bassetlaw currently has the lowest. We know that obviously that breastfeeding is linked to areas of deprivation, and we do what we can to support and increase the rates, which we have done. But yes, Bassetlaw is the lowest rate at the moment.
Just to support Bassetlaw out there, they're making massive improvements, and their data this year has been amazing. So although we're still the lowest, we are really making positive steps.
Just going on to the next one. Right, here we are. So the next one is, apologies for this being so long, but we did want it to be interactive. So, what are the national 6 to 8 weeks breastfeeding prevalence rates? So we generally about 6 months behind the national rate before it's published. So interesting. So nationally, the national rate is 52%. So 33% have answered. So it used to be 47%, and nationally the country has increased its rate at 6 to 8 weeks. We know quite a lot of mums initiate breastfeeding. I mean, nationally, it's around 78 to 80%. And across the counties, I've said we do vary between sort of 60 and 80%. But sadly, a lot of mums give up pretty quickly, well before 6 to 8 weeks. And it's really important for us to then ensure that we can support them to continue successfully. So the last, oops, just the last question. So that was the national, and I think I'll yes,
we've put the rates up now.
Oh, okay. So the rates for Nottinghamshire, you can see that this is for 24 to 25. So the way that we gather data is that health visitors go in to see the family on their first birth visit between day 10 and day 14, and they ask the mum obviously how they're feeding at the time. They then ask them how they fed at birth, and then they ask them, was that the way they were intending to feed? So we ask intention after the event. We know not to ask intention antenatally because you know, if mums choose a method, then they think they can't change. And we find, interestingly, that in every district across our county, more mums actually initiate breastfeeding than we're actually intending to. And we feel it's because we show hopefully most mums antenatally how to hand express, and we don't actually ask them their decision until birth itself. Then you can see that the pattern is the same throughout. There's then a reduction at 10 days, not that great, but then by 6 weeks the rates do drop, and we've got Rushcliffe as the highest, and that's probably the area of greatest affluence in our county, and then there's Bassetlaw in the green. And for the county in general, we're sort of middle of the road, and we are really just below the country's 6 to 8 week rate now, whereas we were amongst the third lowest in the country 10 years ago. So the next slide will show from 2018 the rates for birth, 10 days and 6 weeks, and you can see interestingly, you can see the blip there for national and a little bit for local. So during COVID, what we found was that the breastfeeding rates in affluent areas increased quite dramatically, because maybe there was not much else to do than sort of for mums to really focus on feeding, whereas in areas of deprivation, the breastfeeding rate dropped by 1 to 2% quite dramatically, whether it's different stresses that the families were experiencing. But we're really proud to say that this year, at the end of this year, 24 to 25, our 6 to 8 week breastfeeding rate for the county is 50%, and really that has built gradually. In fact, in I think 2009 it was about 38%. So being baby friendly and working hard to support families has made a huge difference. Thank you. Alison.
So moving on and thinking about things that, as GPs, that you might come across, prescribing and breastfeeding is probably one of the biggest issues. And what we know is that there are actually very few medications that can't be taken with breastfeeding. And it's about all clients having that one-to-one risk assessment around the benefits of the medication versus the risks of having to stop breastfeeding. And as I say, in most cases, dependent on the age of the baby and when the medication's been taken. There are ways of getting around it without mums having to stop breastfeeding. Because for a start, most mums won't want to stop just because of medication. They may decide not to take medication if they're told they've got to stop breastfeeding. But also, it's not as easy as it sounds just to say, oh, you're going to have to stop breastfeeding. Some babies won't readily take a bottle, and so that can impact as well. And stopping breastfeeding can have a really detrimental effect on maternal well-being and mental health. So prescribing is quite a big issue with breastfeeding, and looking at how we can best approach that. And Jo, if you're happy to move on, there's some really good resources that can be used. The BNF is traditionally one that's been used, but NICE guidelines say that shouldn't be the only guide that we use, because it doesn't really give us an in-depth knowledge around breastfeeding. We've just outlined some really good resources for you. So the specialist pharmacy services offer help, and they either by email or phone. If you just gather all the appropriate information before contacting them, and then they will advise whether it's appropriate. There is a website called the Breastfeeding Network, and they have a really good section on there around different drugs in breast milk, and will give information for parents to make decisions. And there's lots of different topics covered there around anything, typical things around things like hay fever, cold remedies, up to more complex things around antidepressants, anaesthetics, medical procedures and everything. So it gives some really good guidance. Jo, are you happy to move on? The GP Feeding Network is a really good network of information for GPs, obviously, as it says, and covers a lot of useful information around feeding generally, but also there's information there around prescribing. Lactamed is a good resource. It is American, but it is up to date. But obviously, being American, there are some medications that are not included on there. The NHS has got some really good access. And obviously, we want to blow our own trumpets as well, in that we're happy to look into things. If there's medications that you're not sure of, we'd be happy to look at anything for you. We have quite a few good resources as well. And obviously, our clinical pharmacists use your own local resources as well. But there's lots of information out there rather than just looking at BNF, which in a lot of cases just tends to have the standard generic information around not using when pregnant or breastfeeding. So it's really important to use what's available. Okay, Jo? The other thing that you will regularly come across in terms of challenges for mum is mums appearing at the surgery because they've got very sore nipples. And often, traditionally, we always look at medical things like potentially thrush and infections and things like that. But in most cases, what we know, the cause of sore nipples is around positioning and attachment, and that being ineffective. So in most cases, the first line of attack is looking at, has that mum had any good breastfeeding support around the positioning and attachment? We do know that teats and dummies can affect it, because babies use a very different suck on a teat, and if they get used to too many teats and dummies, that will affect how willing they are to attach to the breast. Excessive pumping, or if the breast pump doesn't fit appropriately, that can cause really sore nipples. Use of nipple creams. Lots of mums think that if they use a cream, it'll prevent the sore nipples or help them to heal. But in a lot of cases, it just causes soggy skin and can actually make situations worse. And they certainly don't stop nipples from becoming sore. Applying a cream can't stop a nipple being sore if it's positioning an attachment in the first place. Eczema and dermatitis are really common around the nipple area, and can often be confused for other things, but that's often overlooked, the simplicity of it being a simple dermatitis. And then we're looking at more complex issues such as tongue tie, infections, Raynaud's, and we've put thrush there with some question marks after it. And I'll start with this one if you want to move on, Jo. Just to say that a change in approach is imminent. We went to a conference at the end of last year where a prominent consultant had been doing some research into it and looking at what we previously thought might be thrush infections in the breast, and saying that actually the chance of it being thrush is minimal, and to think that women present with that deep stabbing sharp breast pain, but actually because the breast is so well innervated, the nerve network and the blood supply within the breast means that if those nerves at the nipple are irritated, referred pain is very common, and that women can feel pain deep into the breast, still being from positional attachment and irritation of those nerves. And that there is often a lot of overdiagnosis of thrush, and women coming back to GPs repeatedly saying it's not resolved yet and needing further treatment. And the question we threw up, and which was thrown up from the research, is, well, why do antifungals seem to appear to work initially? And that's because it does have an anti-inflammatory effect initially. So mums might feel a little bit of easing at first if there's some inflammation on the nipple, but then the deeper pain from the nerve irritation from position attachment is not addressed, so that they think it's still thrush pain when actually it's related to the nerves. So the actual official guidelines have not yet been changed, but there is imminent work, and the consultant who spoke at our conference was liaising with NATH and with the Breastfeeding Network, who have withdrawn their current guidance around thrush whilst they're waiting to see what changes. You have to move on, Jo. We know that babies do get thrush in the mouth, and sometimes it can transfer onto the nipple, but what the latest research is saying that usually that's not as a pathogen, it's more just as a commensal, and is quite common. And although baby might need treating if it's excessive in baby's mouth, now we don't necessarily need to treat mum if she's showing no symptoms. And also the research was showing that although we have previously thought swabs might diagnose this, because Candida naturally occurs on the skin, sometimes a swab can be misleading. And it's really important that we consider these changes, because a wrong diagnosis often leads to wrong treatment. So if a mum is being treated for thrush and getting repeated treatments and it's not helping the pain, she's actually getting unresolved symptoms. Whereas if we address the matter and look at it wider and think, is this a positional attachment, she might get the right treatment earlier and her symptoms resolve earlier. So it's really important that we look at this, and as soon as we hear anything where guidelines are officially being changed, then we will let everyone know. But at the moment, just to be mindful of, is thrush the right diagnosis? So what else might it be? We're looking at different causes of soreness, redness, irritation around the nipple. As we said, dermatitis aggravated by shells and pumps, and also by the baby's latch at the breast. Neuropathic pain, which is that deep pain, if the latch has been pulled, the nipple's being compressed, and neuropathic pain can be really severe for mums. Could it be a tongue tie? Has baby got difficulty with functioning with its tongue? Is it still just down to the basic position and attachment? And so in both of those situations, it's about ensuring that the mum gets effective breastfeeding support rather than a prescription. So it's just looking at what the wider issues might be, and considering what possible treatments it might be. So making sure that mum's got support with the breastfeeding. If she's using creams or anything that might irritate the nipple, to stop that. Simple warmth to the nipple can often help, especially with neuropathic pain. And if there is inflammation or irritation there, a basic steroidal cream can help. And the last point is just to say, one of the things that came up in research that they're looking at further is that they did find that a short-term prescription of SSRIs can be very effective for neuropathic pain. And this is something that they're looking at and considering for future changes to pathways. So not that we're saying to jump in straight away, but it might be something that comes out from the new guidelines around how we treat neuropathic pain in the breast. So, yeah. One of the other causes of nipple pain is Raynaud's. Mums might have a history of Raynaud's in their fingers and toes, in which case, if they're experiencing changing colour in the nipple during feeding, that might indicate that they're getting Raynaud's in the nipple as well. And the ultimate cause for this, again, is around suboptimal breastfeeding and position and attachment not being right, so the nipple's getting compressed, and that's where they get the pain and the reduction in the blood supply. If a mum's not got a history of Raynaud's, it might be just a simple vasoconstriction, but the treatment and the presentation is very similar. So in terms of how we might treat that, move on, Jo. Yeah. Nicotine, smoking really aggravates Raynaud's. So it's around, does that mum need support to help cut down, reduce or stop smoking? Caffeine can be an aggravate. Oh, I can't remember words. That can aggravate Raynaud's and vasoconstriction as well. So looking at caffeine intake, avoiding cold, so applying warmth to the breast. Mild exercise can help. Putting warm sweat. Oh, my words have gone. But warm compresses on the breast after a feed can really help. Decongestants cause constriction of blood vessels, so again can make Raynaud's worse. And in more severe cases, it can, sorry, my presentation moved then. In more severe cases, where the pain is really impacting on mum's ability to breastfeed, nifedipine can be really effective, a short course of nifedipine, to help to reduce the vasoconstriction. And some mums will find that really effective, although sometimes we have problems with the side effects of nifedipine, in that mums get headaches and hot flushes and they feel that they've just swapped one problem for another. But it can be effective in severe Raynaud's.
Right. So I'm going to chat a lot about some of the challenges that mums might come across, that you might come across in general practice. So I'm sure you've probably all come across mastitis, and you'll be aware that the guidance on mastitis changed in 2022, and it's taken those of us that have been around a long time, like myself, it's taken us a little bit of a while to get used to the new guidance, but the new evidence that led to the change in the guidance is really emphasising that mastitis, the big cause of mastitis is an inflammatory response, and it's not that may lead to an infection, but the key cause is usually an inflammatory response. So there might be some ductal narrowing, and then that leads to inflammation. That can be made worse by hyperlactation. So ladies that have pumped to try and clear the breast, actually, that we know now that actually can make the mastitis worse, and that can lead to increased inflammation. And we know that if the inflammation isn't dealt with, that can become an infection. I think we know a lot more now about how dysbiosis in the woman's breast. So we know that can be an issue with mastitis. So making sure that women, we try and not use antibiotics where we don't need them, that we're mindful of women with anxiety and depression because that can increase inflammation. So and also mindful about those ladies that are exclusively pumping, that they might be more likely to get mastitis because their breasts, there's value in the microbiome of the breast. There's value in having some of the baby's microbes. That seems to create a better microbiome in the breast, which helps to reduce the risk of mastitis. Anyway, we suspect mastitis in a lactating woman who presents with a painful breast. She may or may not have fever or generally feeling poorly. She might have a tender red, or if she's darker skin, it may be a darker area that's swollen, that's hard, usually with a wedge-shaped distribution. And as I've said, it's usually an inflammatory response rather than primarily being an infection at the start. So if we think about differential diagnosis of mastitis, one of the things that we need to do is make sure that women are educated in what happens normally with the breasts. It is normal that in the early days of breastfeeding, women might feel some full breasts. Breasts may feel hot, heavy, tender and hard, but if they're not red or painful, and if there's no pyrexia and they feel well, that may just be full breasts. And women some women get that every morning or before they're due a feed, they get feeling of fullness and they might have some lumpy areas, but if that clears when the baby feeds, that's not mastitis, that's normal, what normally happens with breasts, and some women don't understand that is normal for some ladies. Engorgement is where the breasts feel hot, hard, painful, shiny. Milk may not be flowing readily, so women can get that in the initial days when the milk comes in. But if the position attachment is correct, and mum's feeding responsibly, we shouldn't be expecting lots of engorgement. So if we're getting that, maybe we need to ask a few questions about position attachment, about how often they're feeding. Some women are restricted in the number of feeds that baby has, making sure they understand about feeding responsibly, so feeding at early feeding cues, and actually that they can feed before that. If their breasts are full, they can just feed the baby. That's okay. Other differential diagnosis of mastitis, it could be a blocked duct, which might be a painful lump in the breast. It may be red or discoloured, but they wouldn't have any fever. And with a blocked duct, we're encouraging them to feed physiologically. So in the past, with blocked ducts, women have pumped and pumped and pumped to try and clear the duct, and that actually can create a hyperlactation. So we just want them to be feeding at the normal level on that side, or if they're exclusively expressing, express at the normal level, just to keep the milk going. Maybe they need some support with position attachment. Maybe we need to check they've not got a bra digging into the breast or a finger blocking a duct, but they don't need to kind of super empty their breasts. Obviously, another differential diagnosis of mastitis is that it's an abscess, and we know that that's more likely they've had a history of mastitis or abscess, and they could have a history of fever, but then the fever can actually have got better, and because they may have taken antibiotics for the mastitis, but it's still we need to be conscious that it could be an abscess, and the abscess tends to be a painful, swollen area that's discoloured, and on examination the lumps are fluctuant with some skin discoloration, and they obviously need to be referred to hospital for treatment. So in terms of management of mastitis, it's really important that in general practice we really encourage women to carry on breastfeeding. In years gone by, women were told to stop breastfeeding. Obviously, that was the worst thing possible. So really reassure them and encourage them that they continue breastfeeding. A lot of mums worry that they're causing some harm by feeding the baby. So it's really important that we encourage them to carry on feeding and explain that this is the best thing for them to be doing. Arrange support with position attachment, because that could be the trigger for the mastitis. It could be that the position attachment's not great. So making sure that somebody who knows what they're doing has watched to feed and supported with position attachment. And that would be like watching a whole feed and not just kind of giving a little bit of a quick look and checking. Identify any possible causes. Have they been missing feeds? Are they restricting the number of feeds that the baby has? Have they got restricted clothing, position of attachment issues? Encourage them to use simple analgesia. A cold compress after feeds for 10 minutes every hour can really help reduce inflammation. Use of anti-inflammatories can also reduce inflammation, which helps the milk to flow, as well as actually reducing the inflammation. Some women find using some warmth before a feed can help with the milk to flow, but and they're confused about the cold and hot thing, but if it helps, they can use some warmth before a feed or before an expression, but after the feed or expression, then they would use some cold to reduce the inflammation. When I say after feed or expression, what I mean is we might have some ladies that are exclusively expressing. So if women are exclusively breastfeeding, we tell them to feed at the normal level that they're feeding at. So they don't need to feed an excessive amount on the side they've got mastitis. We'd say to feed at the normal level that they were feeding before. But if they're exclusively expressing, we tell them to express at the normal level that they were feeding before. And they need all antibiotics if there's no improvement after 12 to 24 hours of milk removal, and that should be given to 10 to 14 days. I have some ladies that come back with continued symptoms where they've only been given 5 days of antibiotics. And the advice is to use flucloxacillin 500 milligrams 4 times a day for 10 to 14 days. Obviously, an urgent referral to breast clinic if there's a suspected abscess, and hospital admission if there's any signs of sepsis. It's really important that when you give any treatment for mastitis, you say to the mum what they should do if the symptoms don't settle. So if the NICE guidance says that if the symptoms fail to settle after 48 hours of the first antibiotic, they should come back to general practice. So obviously you're checking, have they taken the antibiotics correctly, or could it be something else? And the NICE guidance suggests sending a milk culture at that point, starting a second line antibiotic, but just checking other factors. Are there any predisposing factors? So has this baby got a tongue tie? Is there poor position attachment? Do they need some support with the breastfeeding technique? Have they had a history of lots of mastitis before? Have they had breast surgery? Those sorts of things. Could it be a resistant bacteria? And obviously sending the culture will pick that up. I know I've had some, if I have women that work as health professionals coming that speak to me about repeated mastitis, it's important to check they've not got MRSA. And if there doesn't seem to be a reason why they're getting recurrent mastitis, and you've given them the second line antibiotics and checked for other things that it could be, it's worth referring them to our breastfeeding clinic, because it could be a breastfeeding technique issue, and we can support them with that. That's the link there to the NICE clinical knowledge summary, the updated one on managing mastitis, which I find really helpful. Nipple bleps, or thinking on nipple bleps has changed over the years, and women will still come and say that they want you to pierce their nipple blep for them. So nipple bleps are where there's a clog, and it's usually due to the evidence is that it's due to inflammation, and that's what's caused the clog. And there's often a background of reduced milk flow, so it may be that the position attachment's not been great, or baby's got a tongue tie. So they're usually cleared when the baby's feeding effectively. I've put the link there to the Academy of Breastfeeding Medicine mastitis article, because that talks about bleps, and that suggests using a topical moderate potency steroid cream. They also suggest that a mum could use oral lecithin, and they've got the details of that in that article if you wanted to look at that. But the recommendations are not to pierce with a sharp instrument, but hopefully feeding more effectively and trying the steroid cream should clear that. I just wanted to raise contraception and breastfeeding. One of the reasons for me asking to do this training session for general practice was because I had a mum that came to my clinic, and she was breastfeeding really well, and then she was prescribed the combined pill, her weight chart was really interesting. The baby just stopped gaining weight after the mum had started taking the combined pill, and nobody had said to her, "Oh, your milk supply might drop." It's just a reminder that in our conversations with mums who are breastfeeding and where we're talking about contraception, we just need to give them some information and some choices, really. Some women, even though they know it might drop supply, would prefer to take oral contraception. But for some women, they don't want to do anything that could risk dropping their milk supply. So the progesterone pill, I know the research is there is differing research on the impact of progesterone pill on milk supply, but as lactation consultants, we see a lot of mums where the progesterone pill will drop supply. So if mums do go on the progesterone pill, ideally you want to wait until at least 6 weeks. You want to wait until the milk supply is well established. Now, you could have a lady at 6 weeks who's had a lot of breastfeeding problems and the milk supply isn't really established. So you need to make sure that her milk supply is really well established before using the progesterone pill. And the combined pill, like estrogen, we know that estrogen can drop supply. So the advice would be not to use it in the early weeks with a breastfeeding mum because of the drop in supply. The contraceptive patch, if it contains estrogen, that can drop supply. Progesterone injections or implants, again, with those, wait until milk supply is really established, because progesterone can inhibit the effect of prolactin, which is really significant, involved in milk production early on. With IUDs, mums with breastfeeding can have a simple coil from birth, but if you're using something like if you're using the Mirena, which releases progesterone, the advice would be not to use it until after 6 weeks, because there's some evidence that can drop supply if used under 6 weeks. I've put the link at the bottom to the Academy of Breastfeeding Medicine protocol on contraception during breastfeeding, because there's quite a lot of information on there on the lactation amenorrheal method. So we know that if a baby is exclusively breastfed, and that is not exclusively given milk that's expressed, the evidence is that it does need to be exclusively breastfed. So if the baby's exclusively breastfed under 6 months, mum's not had any periods, and she's feeding at least 4 hourly in the day and 6 hourly at night, that's 98% effective in the first 6 months. So I think if you're having contraceptive discussions with mothers, it's just highlighting that. And actually, if a mum is worried about taking something that's going to drop her supply, if she knows that actually the lactation amenorrheal method is 98% effective, that may be her choice. Explaining to her that if she starts using supplements, or if she gets a period, it's important that she knows she can't rely on that method. I think I would really ask you to really, if a mum has got previous low milk supply, or she's got low milk supply this time, or she's got a history of breast surgery, maybe she's got breast hyperplasia, so there's less glandular tissue there, where she's got multiple births, preterm birth, where she's got any health issue, where there's any health issue in mum or baby, where milk supply is a problem, or if it's really, really important this baby breastfeeds, then really be cautious about hormonal methods and really talk to a mum about that, because some mums, their milk production is even more precious, and I've worked with some mums to get their milk supply up, and then they've been prescribed the pill and it's dropped their supply, and they just say, I just wish somebody had discussed it with me so I could have made the choice. Okay, we've got another quiz. Hello, can you hear me? Have I lost you?
Yes, it's coming up. It should be coming up
no.
now. So Alison, you're doing this.
So have we got
where
are we? Yeah. No votes as yet.
You can choose more than one option in this one.
Okay, so we're getting a variety of different things. Really, I think the only one that we would say is not necessarily a sign of baby getting enough milk is sleeping through the night, because we know that sleep is very much an individual thing for babies, and it just because the baby doesn't sleep through doesn't mean that it's not getting enough milk. It's dependent on the age of baby, the individual character of baby, and what else is happening around it. But certainly if a baby is content during and after a feed, is having wet and dirty nappies, and so up to 6 weeks we'd expect 6 wet and 2 dirty nappies. Babies from sort of 4 to 6 weeks of age will slow down in the amount of stools that they have, and some breastfed babies might only stool once every 5 or 6 days, and that can be quite normal if it's soft and yellow when they go. But certainly in the early couple of weeks, babies should be having a minimum of 2 stools per day, and that could be a really good indicator that they're not getting adequate milk if they're not having that. And obviously if they're swallowing whilst they're breastfeeding, that's a really good sign that they're receiving milk. It's something that mums can very easily monitor. So yeah, the 3 things there.
Okay, I'll launch the next one. Yes,
Yeah.
there is. Just find it's just a little bit difficult once we've brought one up for the next one. I think I've got it now actually. Next one's coming up now. What effects do supplements have on milk production?
Okay, so we've got majority of people say agreeing that it does actually decrease the milk production. If a baby is having additional milk in a bottle, then from a breast point of view, the breast doesn't recognise that that's milk that the baby needs. And in terms of how the breast produces milk, it's very much a supply and demand. So the more milk that's removed, the more milk will be made. If a baby's having a bottle instead of a breastfeed, then that can impact on how much milk is made. Babies come to the breast less frequently if they're having top-ups of formula milk, and so that can all impact on milk production. So it's being mindful of, if a mum says that she is giving some additional supplements, is that having an impact on baby's milk supply? So good.
And then the last one. What factors inhibit milk production?
We're doing really well on this one. Yeah, absolutely. And from what we've said, frequent feeding is not going to inhibit it. It's going to enhance milk production. Cuddling the baby before a feed will encourage the flow of oxytocin, and that will help with milk production. So obviously the one that we don't want is engorged breast, because when the breasts are full, a message is sent to the brain to reduce milk supply, to stop extreme discomfort from one's point of view, but it will inhibit milk production. Brilliant.
Okay.
It's the end of the quiz.
Thank you. Yes, so back to me. So I've just got a little bit more information. I did mention the mum that I told you about a few minutes ago, who'd her milk supply had really dropped when she went on the pill. So I've just got a little bit more information about her. So this mum attended my clinic at 7 weeks. She'd had a history of persistent sore nipples right from the start. But then baby had a static weight. So there had been no increase in weight at all since week 5. She'd attended the GPs on lots of occasions, and she'd been treated for thrush. She'd had topical treatment initially for her and the baby, and then she'd had oral antifungal treatment, and none of it had resolved the pain. So when I saw her at my clinic, I assessed the breastfeeding, checked there wasn't a tongue tie, but her breastfeeding technique was poor. She'd got a really shallow latch, and that was the reason for the pain. And it was significant that she'd had pain right from the start. So that was a a really strong suggestion that it was a position and attachment issue. But also, we chatted about reasons for supply, because it could, the poor weight gain could have simply been to do with shallow latch. But actually, the weight gain, even though she'd had sore nipples, the weight gain had been good up to week 5. And then we looked at what had happened, and the static weight gain had coincided with her going on the mini pill, the progesterone pill. So what we did at the clinic, I got the position and attachment better, so we got the breastfeeding to be comfortable. There were no signs of thrush seen, and the pain was really typical of pain caused by shallow latch, so I told her to stop using the medication for thrush. 1 week later, she'd stopped the mini pill, her milk supply had increased, she'd been using the techniques that I taught her for getting a deeper latch, and baby was feeding really effectively with no pain, and we'd had a really good weight gain, over 30 grams a day. We had a happy mum and a content baby, and she just said that she just wished she'd have been referred to me earlier, but also she just wished that somebody had discussed with her what impact the mini pill could have had on her milk production. So that was a kind of a story that a relatively easy mum to sort out. So I'm just going to chat about a few more challenges now. I'm going to have a little chat about tongue tie, and then Teresa's going to talk about slow weight gain, Alison's going to talk about reflux, and I'm going to talk a little bit about cow's milk protein allergy. So we've thought about some challenges for mum, and now we're thinking about a few more challenges for babies. We've sort of made reference to this already, really, because we've already talked about supply, but the vicious circle of an unsettled baby, which you might see in general practice, if we've got a baby that's for whatever reasons less demanding at the breast, maybe they're really sleepy or they're full of formula, we get then reduced milk production, and then the baby becomes less settled with the breast. We have a hungry, unsettled baby, a tired, worried mother. Feeds might be painful and prolonged, the temptation to offer more formula, and then that kind of leads to even more of a significant drop in milk production. And then conversely, if we have really good attachment at the breast, no nipple pain, feeding at least 8 to 10 times in 24 hours, we've got good position attachment, frequent feeding, we get a good milk production going, and the orders for continued milk production are put in place. We get a content mum, and we got to get a content baby who's gaining weight, doing lots of wet and dirty nappies, and doing efficient feeds at the breast. One of the things when we're looking at things like causes of repeated mastitis, or when we're looking at the baby that isn't gaining weight, it's really important to think position attachment first. But if that seems to be okay, think what else could it be? And one of the reasons it could be tongue tie. So these are some of the symptoms in mum and baby of a possible tongue tie. So in the mum, she might have sore, damaged nipples. She might have nipples which look misshapen or blanched after feed. She might have a history of mastitis, low milk supply, exhaustion from frequent constant feeding, and emotional distress from failing to establish breastfeeding. In the baby, we might notice restricted tongue movement. We might have a small gape, resulting in biting or grinding behaviour at the breast. We might have a baby that's unsettled during feeds, who has difficulty staying attached to the breast or the bottle. We might see frequent or very long feeds, excessive early weight loss, so maybe 10% or more at that initial day 5 weight, and then from then on we might have poor weight gain, we might have faltering growth, we might have clicking noises, dribbling during feeds. We might have a baby that has lots of colic symptoms, really windy, hiccupy, and actually one of the causes of reflux might be a tongue tie. Now, these things in mum and baby could also be signs of poor attachment, so there could be other reasons. But if somebody's looked at position attachment, the next thing we might think is could it be a tongue tie? So I've just got a little bit of information on tongue ties. We've got some pictures there for you. It's important to note that not all tongue ties cause problems. So we don't really know what percentage of babies have tongue ties. Some research says 10%, some research says up to 25%. But basically what we know is that probably. At least 50% of tongue ties don't have any impact on feeding, and there's no reason to cut a tongue tie. The tongue restriction, there's not sufficient evidence that it can impact any other aspect of baby as they grow up. There's not sufficient evidence that it can impact speech or feeding later on in life, but we're looking at how is it impacting the feeding now. And the NICE guidance says that if a tongue tie is impacting the feeding, then that might be a reason to perform a frenulotomy when we get it released. But because we know that 50% of tongue ties don't have an impact on feeding, the first thing we do is get really good position attachment, so that we try and not refer babies where they don't need to have the tongue tie cut. We know that the function of the tongue is probably more important than how it looks. So you can have a tongue tie that looks really significant, but actually the baby's tongue function is really good and the breastfeeding is okay, so we don't need to do anything. There's a risk if we just focus on the tongue tie. What happens is we refer a baby because they've got a tongue tie. But if the tongue tie is cut and the position attachment is still poor, the mum and baby will still have problems. And there are obviously complications from doing a frenulotomy. Baby can bleed. It might not make a difference. It can grow back. There's a theoretical risk, about a 1 in 10,000 risk of an infection, but there are potential complications. So we don't want to do a frenulotomy if we don't need to. One of the resources that we teach our health visitors to use is this simple screening tool called a tabby tool. In general practice, it would be fine for you to use this tool. It's a really simple tool to use. It was devised in Bristol. It's very pictorial. Parents like it because you can show it to parents. I had a GP recently that put the tabby score in the records, which was great. I'll just talk you through it. You're going to get the slides, so you could choose to use this in general practice if you want. But the first item you look at is the tongue tip, and on the top row. And if the tongue is a heart-shaped tongue, so you can see it's really restricted, you score it a 0. If the tongue tip has got a little knot at the end, you score it a 1. And if the tongue nice and round when it's lifted up, we score a 2, so that's full marks. And then we look at where it's fixed to the gum. If it's fixed to the top of the gum line, we'd score a 0, so that's the most restricted. If it's attached somewhere between the top of the gum line and the floor of the mouth, we'd score a 1, and if it's attached to the floor of the mouth, we'd score a 2, full marks. And then how high can the baby lift their tongue up when the mouth's wide open? So if there's very little elevation of the tip or the sides of the tongue, we'd score a 0. If when the baby's opening their mouth wide, for example, when they're crying, if they can lift the sides of the tongue but not the tip, we'd score a 1. And normal tongue lift would be that the tip of the tongue can elevate more than halfway between the base and the palate, and that would score a 2. And then how far can the baby stick the tongue out? If the baby's tongue can't go past the gum line at all, we'd score a 0. If it goes past the gum line but not beyond the bottom lip, we'd score a 1. And if it can go out in a straight line past the bottom lip, we'd score a 2. You can have a tongue that actually is really pulled down, so it does go past the gum, the lip, but it's really pulled down, so you might still score that a 1. 8 indicates normal function. 6 or 7 is borderline, so we do a kind of wait and see approach, get really good support with position attachment, and then kind of see what happens. If there's a score of 5 or less, that might suggest impairment of tongue function, and they might benefit from a frenulotomy, a tongue tie release. But we'd still work on position attachment first, because we know that 50% of babies with a tongue tie, we can just sort it out with position attachment. So hopefully that's helpful. In terms of the Nottinghamshire tongue tie pathway, the first thing to remember is that the health visitor should undertake a feeding assessment, support with position attachment, and refer appropriate dependent on area. So if it's a baby under NUH, if a baby's under 28 days of age, there can be a referral to the NUH infant feeding service, where the infant feeding leads there will make a tongue tie assessment. but they will only take referrals up to 28 days. So if it's an NUH born baby over 28 days, they could be referred to myself, Alison or Teresa as the local community infant feeding leads, and we can do an assessment. We would then have to do the assessment and get the GP to refer as an urgent referral to NUH General Surgery Paediatrics. If it's a Kingsmill baby under 6 weeks, health visitors, GPs or infant feeding leads can refer directly to the tongue tie service, and we put the emails address there. You can either email the infant feeding lead, Natalie Boxall, or you can email that generic infant feeding email address. If the baby's over 6 weeks, you could refer to myself, Alison or Teresa, for us to do an assessment, but we would have to make the request. We'd have to get a GP referral. Again, it would be an urgent referral to the general paediatric surgeons at NUH. The Bassett law, referral by the midwifery service, infant feeding lead can refer to Sheffield Children's Hospital. For the bottle-fed baby, we'd expect that the health visitor should undertake a bottle feeding assessment to support with paced bottle feeding. Possible signs of tongue tie in a bottle-fed baby might be unsettled behaviour during feeds, premature end of a feed due to exhaustion, difficulty staying attached to the bottle, frequent or very long feeds, unable to maintain the suck swallow pattern on the bottle, excessive early weight loss and poor weight gain, faltering growth, and again, as with the breastfed baby, clicking noises, dribbling during feeds, colic, wind, hiccups and reflux. But the first thing would be work on bottle feeding technique and support with paced bottle feeding. So the tongue tie referral options for bottle fed babies. The GP can do a referral to NUH General Surgery Paediatrics, as we've already said. We've already under 6 weeks. Natalie will, the tongue tie service at Kingsmill will cut tongue ties for babies who are bottle fed under 6 weeks, but it needs to be a GP referral for the bottle fed baby. But over 6 weeks, those Kingsmill babies, it needs to be a GP referral to NUH General Surgery. And Bassett law, it needs to be a GP referral to Sheffield Children's Hospital. So it does seem a little overcomplicated. Okay, anybody got any comments or questions about the tongue tie pathway? Okay, I'll pass on to Teresa.
Thank you, Jo. So weight gain, weight loss is often a worry for many parents and healthcare professionals as well. So in the early days, initial weight loss of 8 to 10%. So, you know, this could be within normal limits. It really depends what else is happening. So it does need careful assessment of the baby, check how the baby's doing, and a feed needs to be observed and breastfeeding support activated as well. So it could be that the baby had lost more weight and it's slowly gaining, even though it might still be 8 to 10% below birth weight, in which case things are working well, but they need to be monitored. However, if there's been no support of feeding, then a careful breastfeeding assessment, looking at everything, looking at how mum's feeding. As Jo has said, position and attachment is the largest issue. It's 94% of any breastfeeding problems are poor position and attachment. So that is really the first port of call. But we wouldn't just sit on 8 to 10% loss. We would assess, check feeding and make any improvements as required. If the baby, we also check if the baby's not back to birth weight 14 days post delivery. Again, we assess feeding, we look at the breastfeeding technique. It's really important to ensure everything with regard to breastfeeding, and mum is supported to ensure that she has an effective milk transfer. So looking at that, it might be that she needs to feed more frequently. We ask what's happening at night. It might be a deeper latch. If mum's got painful nipples, that will generally always ensure that baby gets less milk, because if mum's got painful nipples, she will have more stress, she will have less oxytocin, and her letdown won't be as effective as when she's pain-free. So painful feeding needs immediate attention, and as Jo has said, referral to either ourselves or the health visiting team for support is really crucial. If the baby's not back to birth weight by 21 days, it definitely requires a further investigation. And again, it depends what's happening. It includes assessment of feeding and technique, as we said above. We would ask the mum to make an appointment with yourselves, GPs, so that you can rule out any other reasons for the slow weight gain or the weight loss, anything other than feeding. So any medical reasons, hence mums come to be seen at practice, just to rule that out. If as a GP you assess the baby's doing absolutely fine apart from the weight, we can then continue to focus on feeding, and it's increasing breastfeeding technique, breastfeeding, and depending on the amount that the baby's lost or not gained, supplementation may be required, but it's important at the same time to ensure breastfeeding continues as well as possible. And we need to strike a balance, because supporting mum and her not losing confidence in breastfeeding is essential. If she starts to worry about the weight, she'll have more stress, she'll have less oxytocin, and that might actually result in less milk transfer. So it is a really careful balance to protect breastfeeding, but also ensure that the baby's getting the nutrition that it needs. So the next slide, I think Joe already went through the signs of effective breastfeeding, and your output is crucial. So obviously urine output, 6 to 8 wet nappies. The stools are really important. So up to 6 weeks, we expect 2 stools a day. It doesn't have to be a lot, but at least 2 stools. If there's less than 2 stools, that would indicate not enough milk transfer to the baby. And sometimes we see babies are given lactulose to help them pass stool, but it's all about feeding. The baby needs milk at this stage, so it's increasing milk transfer, and that should increase the stools. After 6 weeks, 4 to 6 weeks, the baby might start to poo less, they might start to poo 2 to 3 times a week, but mum knows what's normal. Or some babies continue to poo several times a day. It depends what else is happening. With regards to faltering growth, so this is taken from the NICE guidance, and we work on the thresholds for concern. And so this, you can see here, this is the centile charts, and if the baby is below if the birth weight is below the 9th centile, then a fall of 1 centile or more will trigger investigation and support. If the baby's weight at birth is between the 9th and 91st centiles, then a fall of 2 or more centile spaces would trigger concern. It might be that the baby between 9th and 91st centiles just drops 1 centile. We look at everything else. That wouldn't trigger concern necessarily. We look at everything else. We assess feeding, build the mum's confidence, and we would review again, won't leave her, but we would review. And in these cases, face-to-face support is crucial. If the baby's above the 91st centile, then it's a fall of 3 or more centiles that would trigger concern. But basically, for between the 9th and 91st, it's a fall of 2 centiles, whatever the birth weight, would trigger concern. Thank you, Jo. So causative factors for slow weight gain would be in the baby pre-existing conditions, so any cardiac or respiratory problems, neurological problems, which is what we obviously ask them to see cells for, facial or any oral abnormalities. So as Jo's already discussed, tongue tie can really result in slow weight gain because babies often stop feeding because they're tired, not because they've had enough. Any oral issues, so cleft lip or cleft palate, lack of tone, a baby being premature, you know, baby even up to 36+6 sometimes do have issues and are slow to gain weight, or digestive problems, so reflux and lactose intolerance can affect babies. An insufficient milk intake can be caused by any ineffective attachment to the breast. So sore nipples, you know, a really quick way. If mum's got sore nipples, she really needs support because that reduces the milk flow. Restricting feeds or infrequent feeds, we expect 8 to 24 feeds in 24 hours, particularly I'd say 2 feeds between midnight and 6 a.m. If parents use a dummy pacifier, that might mask feeding cues and it might soothe the baby, resulting in the baby not coming to the breast for a feed when they're ready. So it would be addressing that. And also if the baby has any fluids other than breast milk that would reduce baby's appetite, so baby doesn't go to the breast as soon as it would do otherwise for breast milk. Thanks, Jo. So as GPs and management roles, it is as said, exclude and treat any illness if diagnosed. Also refer urgently via our Healthy Family Teams advice line. So we have specialist clinics, but the easiest way is to contact that one phone number to the advice line, and they would book the mum in to the district that's most suitable for her, or the soonest appointment. It might be that support from the health visitor is adequate, but certainly refer for position attachment support. Encourage mums to express milk between feeds. It's not about the length of expression, you know, 5 minutes expressing might be enough, but it's the frequency. So if the mum can manage a few times a day to increase milk production, she can either do hand expression or use a pump. Lots of snuggles and cuddles, so anything she can do to increase her oxytocin, so cuddling baby, cuddling other other children, partner, the 8 to 10 feeds in 24 hours. Always inquire, is she offering both breasts at each feed, to ensure that baby has a good feed, but offering both breasts is quite important. We said at least 1 feed, if not 2, during the night. And consider prescription medicine. So if we see if we do talk about domperidone, we'll talk about the domperidone to increase milk production. There are foods that have been shown to increase breast milk production, and they include anything to do with oats, oat milk, oat porridge, oat cookies, fennel tea, green leafy vegetables. So the next slide covers responsive breastfeeding. So responsive breastfeeding really tells us when should the mother offer her breast to the baby. So it really is any and every opportunity. So responsive breastfeeding is mum offering the breast whenever baby shows feeding cues, and it's early feeding cues when they're starting to root, or if the baby's feeling a bit low, distressed, in pain. If mum's breasts are full, she can offer the breast sooner. If she needs to nip out to see the, for any appointment, she can feed the baby sooner. If she wants to just sit down and cuddle her baby. So, we said the baby has 8 to 10 meals at the breast, but they can also have like extra snacks, so 2-minute feeds here, 3-minute feeds there, because babies cannot be overfed or spoiled by breastfeeding. So breastfeeding directly from the breast, they cannot be overfed, because if they don't want food, they just won't feed. They can be overfed if they're fed by bottle, but with breastfeeding, it's offering the breast at any and every opportunity. Thank you. So this is a the semi-recline position, which we find works really, really well. If the mum is relaxed and happy, i.e. pain-free, then she will relax and she will have a really effective and optimum milk transfer. You can see in this position, baby's relaxed, mum's relaxed. It's obvious she's not in any pain. We find this position works really well for mums. They find it quite comfortable, particularly if they've got sore nipples, because it necessitates the baby to actually attach to the breast. So they use their reflexes to attach to the breast, and it's useful for the baby has reflux, then the tummy is lower than the mouth, so it can work well. If the mum's got large breasts, this semi-reclined position can work well, and if she's got a strong milk ejection reflex, this can also reduce the severity, but it also allows the baby to be able to tilt their head back to be able to cope. It opens the throat, so they're able to cope with that strong letdown, so they can gulp in comfort. So we do use this position quite frequently. Thank you, Jo. And I mentioned domperidone. So if we've done everything to support the mum to increase her milk transfer, it might be that domperidone has been shown to increase prolactin. It is off-label medication, so it's not licensed in breastfeeding. Domperidone is a dopamine antagonist, and it can antagonize dopamine-induced suppression of prolactin secretion. So it promotes the release of prolactin from the pituitary, thereby increasing milk production. There's further information here as to which mothers can't be given domperidone, and it's those mums with cardiac issues. So they've got more details here, and sometimes also it depends if they're on other medication as well. The usual dose is 10 milligrams 3 times a day for 10 to 14 days. So generally what we recommend is that at this stage we will be seeing, the feeding specialist will be seeing the mum, and we have a letter that we send to GPs via System 1 requesting this, because domperidone is more effective if the mum is expressing and breastfeeding frequently and breastfeeding well. Domperidone on its own without those issues might not be effective, so we don't really want the mum to have domperidone in the first instance, because it might not be effective and then it's almost a waste of it. So we do find 14 days worth works well, and research shows if after 10 days full dose, then the mum is supported by us to wean off gradually. So then we give her a regime of reducing the 3 tablets to 2 for a few days and the 2 tablets to 1 for a few days. So it really kickstarts her body into producing more and more prolactin. We find that it is effective for most mums, and once the milk has increased and they stop the medication, most of the time they're able to continue producing adequate milk. So the last slide, Jo. There are useful resources which you'll get. The GP and Feeding Network, GIFIN, has got a really good resource, and they discuss domperidone, as does the Breastfeeding Network. Thank you. Ali.
So what are the other, Jo, can we move on? One of the other big things I'm sure GPs you come across is reflux. And we know that reflux is really common in babies, and most of the situation it's about the immaturity and the low tone of the esophageal sphincter rather than an acid issue. Babies do need some acid in their tummy to break down the milk and break down the proteins, and also to absorb all the necessary minerals. And also the acid in the stomach helps protect against infections, and keeps the pH levels in the stomach appropriate. Reflux is considered normal in babies, certainly mild to moderate reflux. Oh, sorry, my screen's just gone off. Just bear with me a second. Oh, There we go. Oh, sorry about this. My screen's just gone blank. I was just signing that in again. So yeah, we know it's normal. Babies pull faces, they might whinge a little bit, but generally will soothe quite easily, and not usually with sort of mild to moderate reflux, and not usually in pain, and are often referred to as, you know, happy spitters, the babies that will bring some milk back up, but their weight gain is fine. And their behaviour is fine in terms of how they are at feed time and between feeds. And there's nothing going on, nothing else that might make us suspect either worsening of reflux or any allergies or anything. And in these cases, parents just need that support and reassurance to know that it is okay, and that most babies resolve this in their own time as their system matures. We move on, Jo. And this is reflected in the NICE guidelines that if the baby presents with what we call effortless regurgitation, then just to reassure parents that it resolves by a year of age and doesn't need any further investigations. And there's some links there for really useful resources. If baby's breastfeeding, again, this might be an issue to look and make sure that position attachment is right. Are they getting good support with breastfeeding? If they're bottle feeding, looking at pacing the bottle feeding, and reducing the amount of milk that they're taking at each feed, maybe slightly smaller feeds more frequently, but generally at this stage medication is not required. Okay. Obviously some babies do get more severe forms of this, and gastroesophageal reflux disease. It may be suspected if they present with other symptoms. So, you know, your baby's excessively crying, the arched neck just can't be put down at all. Babies having a bit of a cough or having a hoarseness of their voice. But any baby that's had an episode of pneumonia, the reflux might be suspected. Choking, gagging, feeding difficulties. And obviously if there's an impact on growth, that might make us suspect that something more is going on there. So it's about that individual assessment. So how do we assess babies? Looking at the history, find out what the symptoms are, when did they start, what's happening with feeding, are they breast or bottle feeding, is the baby, you know, if it is bottle feeding, is it taking too much at each feed, and just looking at, is there anything else that we need, any other red flags that we need to be looking at, any alternative diagnoses, a general examination, looking for things obviously like fever, dehydration, any abdominal discomfort or distension, any respiratory problems, is there any problems with growth, weight, neurodevelopment, and has a feeding history been undertaken? Sorry, my phone. And you know, as that mum had support from a health visitor. We'll move on. And how we might manage it. Again, this was taken from the NICE guidance around, first of all, consider offering that support and information about managing feeding and breastfeeding technique, position and attachment. In a bottle-fed baby, looking at a 1 to 2 week trial of reducing volumes, and then potentially if a baby is being formula fed, is what do we look at offering trials of thickening the formula. Carabel is something that is often used as a thickener, and would it, moving on from that, the next line of attack is a short course of something like Gaviscon, and monitoring that so that if it's not effective, that we don't carry on with unnecessary treatments, really. Reflux is something that is a standalone, but also can sit alongside as one of the symptoms of cow's milk allergy, cow's milk protein allergy. So is it worth investigating that a bit further? Is there any other symptoms that might indicate that? If the Gaviscon's not being effective, then sometimes a 4-week trial of something like omeprazole can help, again, monitoring that effectively. And it might be that if symptoms really severe or persist, it might be when a referral to paediatric consultants might be necessary. And again, the guidelines there from NICE, but often it's about reassurance and support for parents without even needing medical treatment. Just move on again. Oh, that's me, I think. Yeah, that's the end of my bit.
So Alison did mention cow's milk protein allergy. I think you're probably aware that we massively overdiagnose cow's milk protein probably in babies, don't we? There is some evidence that came out a couple of years ago where they really looked at this and identified that quite a lot of babies who are diagnosed with cow's milk protein allergy haven't got it. The formula companies would quite like lots of babies to be diagnosed with cow's milk protein allergy because their specialist milks are quite expensive, and so and it's a kind of another more money for them, really, me being cynical. We know that probably about 0.5% of exclusively breastfed infants show reactions to cow's milk protein allergy compared with 2 to 7.5% of formula fed infants. That's relatively old research, but the figures are a little bit kind of not really sure, are we? But we know that the level of cow's milk protein present in breast milk is really, 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 really tiny compared with the amount of cow's milk protein in cow's milk formulas. It's thought that there's lots of immunomodulators present in breast milk, and we know that the gut microbiomes of breastfed baby are really different to that in the formula-fed baby. So there's lots of evidence that the breastfed baby is much less likely to be reactive to cow's milk protein. We also know about this amazing compound secretory IgA, which is in breast milk, which kind of coats the gut and prevents penetration by allergens, which is not something that's in formula milk. We know that lots of the symptoms of delayed allergy can actually be normal physiology, and that we do probably, as I say, overdiagnose cow's milk protein in babies, and it can be really significant. I mean, it can lead to increasing costs because you guys in general practice may be prescribing hypoallergenic formula, but for a breastfed mummy, it can be really difficult to exclude dairy from her diet. So obviously, if we suspect cow's milk protein allergy in a mum's breastfeeding, the first thing would be she trials a diet without dairy in, but that's really difficult. So we have to be totally sure that is the case, because it could kill her breastfeeding if it's really difficult for her to exclude dairy. It is really expensive. So in parts of the county with high levels of deprivation, it's a really, really big thing for a mum to go dairy free, and we only want to do it if we're really sure that if we've explored every other option. You guys are aware that the IgE mediated, the immediate allergies, that's kind of clearer, isn't it? It's the non-GI IgE mediated, the delayed reaction, which is a bit more tricky. And we just have to remember that babies cry for lots of reasons, and a lot of the reasons baby crying are just fall within the range of normal infant behaviour, and we know that if parents get very anxious about the baby crying, that actually makes the crying worse. The Healthy Family team can refer babies and mums in Nottinghamshire to a study at the moment, which is looking at using CBT for families where there's where parents are reporting that babies cry a lot. We know that there's lots of other ways we can manage crying where it's we feel it's probably not allergy. So yeah, when we're testing for cow's milk protein allergy, it's important to remember that it's normal for babies to cause it, but parents may need extra support with a baby that cries. And it's important to remember that colic, the unsettled babies, the root of it could be breastfeeding issues, it could be latch issues, it could be tongue tie. So it's really important that we make sure that that's in place. And with formula fed babies, it's really important that somebody supported them to wash a feed and get the feeding technique as good as possible. And remember that if a bottle fed baby, if parents are looking at the tins will encourage higher volumes of formula milk than actually is currently recommended. So in terms of diagnosis, obviously if it's IgE mediated, that requires a referral. But if it's for those with the non-IgE mediated allergy, the only way of diagnosing it is a trial of dairy-free for 2 to 4 weeks, and then we introduce dairy to see if that makes a difference. But we should be really encouraging breastfeeding with these babies, because if there's a history of atopy and a risk of atopy, it's really, really important that the baby's breastfed. If the cow's milk protein allergy is confirmed, then there should be a referral to paediatric dietitians for advice on mum's diet, breastfeeding, but also on complementary foods. I just wanted to highlight that it can be really difficult in general practice. People can ask you about choice of milks and things generally. I just wanted to highlight this resource, First Steps Nutrition, which is a public health nutrition charity. It's recommended as a useful resource by NICE. There's lots of information generally on bottle feeding for parents, but also for health professionals. Lots of information on specialist milks as well. And some really good resources on nutritional equivalents. So if you know, if a mum asks you in general practice what milk to use, you know, presuming baby's not got a cow's milk allergy or any cow's milk protein allergy or anything, but if she's asking which formula milk is the closest to breast milk, we've got lots of information on First Steps to back up that your response should be that they can pick the cheapest milk that they can get locally, because if it's a UK milk, it's a closely regulated market, so if something needs to be in it, it can be in it, so they can pick the cheapest first milk they can get locally. But lots of information on formula milk on that website, but also on specialist milks if you want that information on specialist milks. And just as a reminder that the key information that parents who are formula feeding need to know are to pick a first milk, and from any company, any brand, cheapest first milk that they can get, and they can be on first milk to the year. And we really need to be encouraging parents to use cow's milk from a year. And the SACAN report, the most recent SACAN report says that they can go on unless there's a weight worry, they can go on semi-skimmed cow's milk from a year. The advice used to be full fat, but now it's semi-skimmed. But all the information on preparing and sterilising and responsive bottle feeding is on that website for this we mentioned there. Okay, Therese.
All right, so we're drawing to a close. We want to leave enough time for any questions that you may have. So this slide just reinforces the international code. You know, it's important to avoid any advertising on infant formula in healthcare settings, because if we advertise one brand, as Jo has said, all milk brands are they all contain the nutritional requirements that a baby needs, and we don't want to encourage parents to spend more money on a brand that's more expensive that doesn't give them anything extra. We know that advertising can be misleading, and all the brands sort of vie for parents to choose their brand, and then they want to keep them there using their brands, and it really does undermine a parent's confidence in breastfeeding. If they see an advert for baby bottle feeding who's happy and sleeps through the night, that doesn't sort of give the long-term health benefits. And our parents expect from all of us to provide reliable and biased evidence-based information about infant feeding. So we're always conscious that we provide resources that are unbiased, that aren't from profit-making companies. Thank you, Jo. So we have got a breastfeeding friend in the community scheme across Nottinghamshire. So this really increases. We want a breastfeeding friendly culture in our communities. So we'd like to encourage any practices that aren't signed up for this. If you ask your practice manager to make contact with us, or there'll be our contacts there at the end. You'll be able people to see, but to sign up to be breastfeeding friendly, and it just gives mums confidence that they'll be able to breastfeed without anyone asking them to move. A lot of our venues across Nottinghamshire, we did have, well, we're probably coming up to over 100 now, are signed up to this, so hopefully it supports mums to feel confident to breastfeed out and about in their communities. So continued support for breastfeeding. Joe, next slide, please. These are our details. We have got a Facebook page for called Not's Happy Baby Corner for parents to get support from each other. They get a lot of support from peers, from other mums that are feeding. There are details here. Probably the easiest way is to contact us via our email. If you would like to refer to our clinics, next slide please, Joe. These are details for our clinics. So we hold I think 5 clinics each week across the county. This sort of poster is aimed at health professionals. We don't, these clinics are for complex issues, so the 3 of us lactation consultants run these clinics, and we really can only see mums with complex issues. The healthy family teams, the health visitors, have received training every year, so they can provide breastfeeding support generally as much as mums need. But if there's complex issues like we've stated, they can be booked in. The appointment number is there for you. You can book them in directly if you wish. We also have weekly breastfeeding support groups in probably about 2 or 3 groups per district across Nottinghamshire. So it's 2 to 3 groups in each district across Nottinghamshire, and these groups are they have family hub staff in, they have peer support volunteers who are all mothers who have breastfed, and they really are brilliant at supporting mums to continue breastfeeding and to maintain their breastfeeding, and they support mums with information if they're ready to return to work, nighttime feeding, so it's the long-term feeding. So we find it really positive supporting families. Thank you, Joe. You'll be able to access these fact sheets that we've already mentioned. And then my final slide is supporting city care. If there's any of you that are here from Nottingham City, this is a slide sharing with you the support that families get from the health visiting teams and also from family hubs. There's 9 areas across the city that offer breastfeeding support, drop-in sessions, and also there's the contact number if you'd like to reach the Healthy Family Team advice line number for the city. City and county are different with regard to breastfeeding support. And then